Before asking how much a treatment helps, ask how much risk is present before treatment. This is not a statistical courtesy. It is bedside medicine. A relative risk reduction has different meaning when the baseline risk is 3%, 16%, 34%, or 57%. The patient's history and cervical length determine the probability space in which treatment is being considered. Start again with cervical length. The Iams study measured cervical length around 24 weeks and showed a graded relationship with spontaneous preterm delivery before 35 weeks. The risk did not suddenly appear below a magic line. It rose as the cervix shortened. At or below 26 millimeters, roughly the 10th percentile, the relative risk was about 6.2 compared with women above the 75th percentile. At or below 22 millimeters, the relative risk was about 9.5. At or below 13 millimeters, it was about 14. The memory is the gradient. 26, 22, 13. Shorter cervix, higher risk. The numbers are not meant to be recited as an isolated chant. They are meant to make the cervix as continuum model unforgettable.
Now, translate that gradient into absolute risk. In the Iams cohort, a cervix of 25 millimeters or less at about 24 weeks corresponded to about an 18% probability of spontaneous delivery before 35 weeks. A cervix of 30 millimeters or less corresponded to about 9%. 20 millimeters or less was higher, about 26%. So if someone says that the risk with a short cervix is around 7 to 15%, the next thought should be which cervix, which population, and which endpoint. Society for Maternal Fetal Medicine gives a useful contemporary nulliparous screening frame. In a cohort of more than 9,000 nulliparas, cervical length 25 millimeters or less at 16 to 22 weeks had a positive predictive value of about 16.2% for spontaneous preterm birth before 37 weeks, but only about 7.4% for spontaneous preterm birth before 32 weeks. The same cervix threshold gives different risks because the endpoint changed. Before 37 and before 32 are not the same question. That continuum also explains why trial placebo arms differ.
In the Fonseca trial, women were selected from routine mid-trimester cervical screening, and the cervix had to be 15 millimeters or less. That is a very short cervix. In the placebo group, spontaneous delivery before 34 weeks occurred in 34.4%. Store that as a baseline risk number. It is not a treatment result. It tells you how enriched the population was for early preterm birth. In the pregnant trial, the population was different. These were asymptomatic singleton pregnancies with cervical length between 10 and 20 millimeters at 19 to 23 plus 6 weeks. The placebo risk of preterm birth before 33 weeks was 16.1%. Do not force these two numbers to be the same. Fonseca used 15 millimeters or less and an under 34 endpoint. Pregnant used 10 to 20 millimeters and an under 33 endpoint. Different entry criteria and different endpoint, different baseline risk. This is why the phrase short cervix has a risk of early labor of 7.5 to 15% is not a satisfying evidence statement. Risk of what endpoint? In what population? With what cervical length? At what gestational age? With or without prior spontaneous preterm birth? A number without its denominator and endpoint is not clinical knowledge. Now add obstetric history. McManemy studied recurrence risk in women with 3 consecutive singleton live births. The key result is beautifully clinical because it shows how history behaves like a probability engine.
If the first 2 births were term, the risk of preterm delivery in the third birth was about 5%. If the first birth was preterm and the second was term, the risk was 13%. If the first was term and the second was preterm, the risk was 21%. If both prior births were preterm, the risk was 42%. The order matters. A more recent preterm birth carried more risk than a more remote one. The number of events matters. 2 prior preterm births carried much more risk than 1. Severity matters too.
Among women with 2 prior very preterm deliveries, between 21 and 31 weeks, the recurrence risk reached 57%. This is not just a list of percentages. It is a structure. 5% means no prior preterm birth in that sequence. 13 and 21% mean 1 prior preterm birth, but order changes the risk. 42% means 2 prior preterm births. 57% means 2 prior very preterm births. The memory is frequency, order, severity. Now connect history and cervical length. A 22 millimeter cervix in a patient with no prior preterm birth is already meaningful. The Iams gradient tells you it is not benign. But a 22 millimeter cervix in a patient with 2 prior very early spontaneous preterm births leaves in a much more dangerous probability space. The ultrasound number did not change. The prior probability changed.
The Preterm Prediction Study made this concrete in Paris women. Among women with prior preterm birth and a positive fetal fibronectin, the estimated risk of spontaneous preterm birth before 35 weeks was about 65% when the cervix was 25 millimeters or less, 45% when the cervix was 26 to 35 millimeters, and 25% when the cervix was more than 35 millimeters. If fetal fibronectin was negative, the same cervical length strata were about 25%, 14%, and 7%. That matrix should permanently change how you hear the phrase history of preterm birth. Positive fibronectin plus a short cervix is not the same clinical state as negative fibronectin plus a long cervix. Both patients have history. They do not have the same current probability. That is why baseline risk must be taught before treatment effect. If a trial reduces a relative risk by about 40%, the absolute benefit depends on where the patient started. A high-risk patient can have a larger absolute benefit. A low-risk patient may have a smaller absolute benefit. And a screening program in a low-prevalence population may show limited public health effect, even when a treatment is biologically useful in selected individuals. This also protects counseling. A patient should not hear a generic statement that the risk is high. She should hear a probability that belongs to her phenotype. If she has a very short cervix before 24 weeks and no prior preterm birth, we should explain the short cervix trial evidence. If she has a prior spontaneous preterm birth, we should explain recurrence risk and how cervical length modifies it. If she presents after 24 weeks, we should explain that late detection changes the evidence. The resident should leave this module with one reflex. Never quote a risk number naked. Attach it to the source population. Attach it to the endpoint. Attach it to gestational age. Attach it to cervical length. Attach it to prior history. Only then is the number useful enough to guide treatment.